Hello everyone, welcome to my presentation. I went to Midyear earlier this month and I will be discussing one of the CE sessions I went to. Evidence-based updates on current topics in pediatrics is one of the sessions I attended. I will focus on delirium in the intensive care unit for this in service today. The last 20 years have provided an explosion of research related to delirium in the adult population, dementia in the elderly, post-intensive care syndrome, and now to the ICU liberation period. To the journey towards ICU liberation, there is now a need to clearly understand delirium in pediatrics, and our gold standard treatments are now being questioned. What is exactly the right thing to do? Heavy sedation, bed rest, no memory of intensive care unit stay, opioid and benzodiazepine infusion combinations. There are three types of delirium: hypoactive, hyperactive, and a mix of the two. Hypoactive, you will see a decrease in dopamine and an increase in acetylcholine and GABA. Hyperactive, you will see the opposite. There is an increase in dopamine and a decrease in acetylcholine and GABA. There is a significant impact when it comes to financial burden, as you can see here on these two wonderful graphs. Total PICU costs are a lot higher in patients that are delirious, and the costs grow exponentially the more days the patient is delirious. You also have to consider other things too, such as the longer length of the intensive care unit stay, the longer length of hospital stay, as well as association with in-hospital mortality. Modifiable risk factors are here on the left side of the slide: benzos, opioids, anticholinergics, steroids, as well as restraints. Non-modifiable risk factors include age less than 5 years, developmental delay, severity of illness, mechanical ventilation, and vasoactive measures. There are 3 assessment tools that can assist in identify delirium in pediatric patients: CAPD, PCAM-ICU, and PEAS. CAM-ICU. CAPD is for all 3 types of delirium, is 94% sensitive, and has a specificity of 79%. It is really quick to complete, around 2 minutes. And 8 elements of the test correlate with the DSM criteria for diagnosing delirium. There are developmental anchor points created to better assess children less than 2 years of age. A score of greater than 9 indicates delirium. PCAM-ICU is for children greater than 5 years old. It is 83% sensitive and has a specificity of 99%. This test requires a presence of inattention. It evaluates 4 features of DSM delirium diagnosis. Feature 1 and features 2 are needed, plus either feature 3 or feature 4 to indicate delirium diagnosis. There is an assessment of inattention, for example squeeze hand when you hear the letter A. There is also an assessment of disorganized thinking, for example a question might be asked like, is sugar sweet? PEAS. CAM-ICU is for children greater than 5 years old. It is 75% sensitive and has a specificity of 91%. This test requires a presence of inattention. It evaluates 4 features of DSM delirium diagnosis. Feature 1 and features 2 are needed, plus either feature 3 or feature 4 to indicate delirium diagnosis. There is also an assessment of inattention, for example show alternating pictures or mirrors while giving verbal prompts like, is this a truck? There is also an assessment of disorganized thinking, for example is there a sleep/wake cycle disturbance like sleeps most of the day or does not awaken easily to stimulation. There are pros and cons associated with each test. The CAPD can be used in all ages and is quick to complete, however it is subjective and you need training on the anchor points. The CAM-ICU tests are objective and also quick to complete. However, they are not used in ages less than 6 months and they are not validated in patients with development delay. For managing ICU delirium, you want to consider the big picture. Is there an underlying illness? Iatrogenic causes? Environmental causes? If non-pharmacologic options do not fix the delirium of the patient, then pharmacologic therapy can be considered. Delirium bundles have been used. A study dose in a 19-bed PICU in an urban, academic medical center implemented a bundle containing 3 components: a delirium screening protocol, a sedation protocol, and an early mobilization protocol. This was a study period of 22 months, and they reduced their average monthly delirium from 19.3% to 11.8%. Other options include day/night orientation, noise reduction, clustering care with family engagement, and discontinuing unnecessary medications. This is where pharmacy can play a huge role. Pharmacologic options include haloperidol, risperidone, quetiapine, olanzapine, and ziprasidone. Sorry if I mispronounced those. Here is a summary slide of the antipsychotic medications with starting doses, dosage forms, dopamine 2 receptor binding, acetylcholine receptor binding, extrapyramidal side effect, and QTc prolongation risk. A few studies have been done in the PICU regarding delirium. Haldol was given to 55 PICU patients with median doses of 0.03 milligrams per kilograms per day. Adverse events were noted in 10% of patients, including sedation, tremor, dystonia, fever, NMS, rigidity, and oculogeric crisis. Seroquel was given to 55 PICU patients with median doses of 1.3 milligrams per kilograms per day for an average of 12 days. No torsades, extrapyramidal symptoms, or NMS were reported. 3 episodes of QTc prolongation were reported, and a total of 2,428 doses were administered. 953 of those doses were given to children less than 2. A case series was reported with Seroquel in complex neonate patients. The doses given was 0.5 milligrams per kilograms per dose every 8 hours. Delirium improved over a course of 2 to 5 days, and sedation was weaned off between 7 and 18 days. The treatment duration was 5 to 8 weeks, and no adverse events were reported. Some things to remember: help them, do not harm them. Keep our patients and devices safe. Emerging research shows that kids can be awake and comfortable and interactive with an endotracheal tube. And be mindful of our patients' developing brains. Non-pharmacologic options can go a very long way. Key points are that pediatric delirium occurs in 25% of our patients, and assessment tools are very essential for early detection. Lastly, remember that when managing ICU delirium, less is more. Optimize the environment and minimize those offending drug therapies before initiating antipsychotic medications. Any questions? You know where to find me. Here is my desk number and my email. Thanks for listening today, everyone.